Welcome, everyone, and thank you for attending today's Public Health Communications Collaborative Monthly Webinar. I'm Dr. Lisa Waddell, Chief Medical Officer of the CDC Foundation. As always, we try to select the topics that will be of greatest interest and support to you. And we have heard from many of you that you're getting questions about children and vaccinations. There are many evolving communications questions relevant to children and vaccinations, from updates to CDC summer camp guidance to vaccine clinical trials for younger children. Even today, the ACIP is holding a benefit risk discussion of the messenger RNA vaccines in adolescents and young children. So as vaccination, authorization, and guidelines continue to evolve for children and adolescents, and as families and officials look ahead to the upcoming school year, this webinar will provide insight into consistent, timely, and fact-based messaging that will help families, parents, the media, policymakers, and the public understand these developments and make decisions. We are thrilled to have Dr. Karen Remley, the Director of the National Center on Birth Defects and Developmental Disabilities at the CDC, and former Executive Director and CEO of the American Academy of Pediatrics, and Dr. Nicole Alexander Scott, Director of the Rhode Island Department of Health, with us today. During the presentation portion of the webinar, please feel free to submit your questions in the chat by sending a message to all panelists. Our speakers will have time to answer several of them at the end of their presentations. And as always, today's webinar is being recorded. That recording will be available at the Public Health Communications Collaborative website later this week, along with all previous webinars we have held and other COVID-19 communication resources. So, next slide. Before we get started, we want to give our speakers a sense of who is participating today and your most pressing communication challenges. This will also help them answer your questions later and helps us plan for the future. So in this WebEx platform, we ask that you please answer the following questions. Which term best describes where you work? You can select one. And then the second question will be, what is your most pressing communications challenge? So we'll give you about a minute to answer this first question. Which term best describes where you work? And if you don't see yourself there, please, by all means, type in the other, check that other. Okay, this poll has ended. We'll see if we get some results. Okay, now it looks like we've got some results, and it shows that actually the large majority of those of you that are participating today are with local health departments. You're there on the ground. We know that you're getting a lot of questions, so I am sure that this will be really helpful for you today. Followed by several people from state health departments, and then a mixture of other colleagues from other places. So let's move to the next question. Okay, let me scroll down. I'm not seeing the results. Okay, here we go. So with the other poll question, it looked like your most pressing issue that you really want help with continues to be vaccine confidence. So I'm sure we'll have some discussion on that today as well. Okay, well, great. So thank you, and we're going to now move to hear from our very prestigious speakers. So first, we're going to hear from Dr. Karen Remley, the Director, again, of the National Center on Birth Defects and Developmental Disabilities at the CDC. Dr. Remley has more than 30 years of experience in leadership in public health and healthcare, including her former role as the Executive Director and CEO of the American Academy of Pediatrics. And following Dr. Remley, we will hear from Dr. Nicole Alexander Scott, the Director of the Rhode Island Department of Health, where she has served as Director since 2015, bringing tremendous experience from her work as a specialist in infectious diseases for children and adults, and as a professor of pediatrics, medicine, and public health. And previously, Dr. Alexander Scott served as the President of the Association of State and Territorial Health Officials, also known as ASTO. So with that, I am going to turn things over to Dr. Remley. Karen?
Thank you. Thank you very much. And thank you, Lisa and Nicole. It's such a pleasure and privilege to be able to speak with the two of you leaders today. As you said, I'm the director of the Center on Birth Defects and Developmental Disabilities, but I've also spent my career being a champion for children, and particularly for people and children with special health care needs. Next slide, please. And we want to talk today about, as we're thinking about vaccinating adolescents, why? And that's a question many of us ask. And I think the important thing here is to look at the trends. So specifically, if you look from the beginning of the pandemic as we go forward, when we had our big peaks of significant disease in the winter, we saw significant increases in adolescents of 12 and 15 years of age and 16 and 17 years of age. And those numbers went up. We don't have the most recent data, but we know that adolescents around the country continue to be infected. And I think that information in terms of what it looks like for May and June will be available later today because it'll be presented at the Advisory Committee on Immunization Practices. Next slide, please. So why do we care if adolescents are getting infected? I think what's really important, this was published on April 11th. If we look that of the 204 adolescent hospitalizations assessed, nearly a third required ICU admission. That was just looking from January through March. 5% required mechanical ventilation, which means a ventilator to breathe for you. The good news is no one died. But as you can see, adolescents are susceptible, more rarely than adults, but certainly susceptible to significant disease. And the good news is the vaccine is eligible to get for COVID for all adolescents. Next slide, please. And we also want to look at COVID deaths in children and adolescents. And here are the counts of those deaths as a percent of total deaths by age group. Between January 1st, 2020 and March 30th, 2021, there were 127 COVID-19 deaths among adolescents, which accounts for about 1.3% of deaths in this age group. I think what's important is many of those were deaths among children and adolescents that had special health care needs that can range from anything to asthma to other healthcare problems. Next slide, please. And many of you have also read or heard about the multi-system inflammatory syndrome in children, or MISC, which is a severe inflammatory syndrome where different body parts can become inflamed, including the heart, lungs, kidney, brain, skin, eyes, or GI organs. Children may have a fever and various symptoms, including abdominal or gut pain, vomiting, diarrhea, neck pain, rash, bloodshot eyes, or feeling extra tired. We still don't know what the exact cause of MISC is, but we know that the majority of children have the virus that causes COVID-19 or they have been around somebody with the virus. Next slide. So I hope I'm telling you why it's important to think about vaccination in adolescents, and in particular, people with developmental disabilities are particularly vulnerable due to having needs for greater health care. They have a higher prevalence of other medical conditions such as asthma, food and skin allergies, and headaches. They may be accessing the healthcare system more frequently, and their illness may have a much greater impact on their daily life, such as mobility and adaptive skills. We also know that many children and adolescents with developmental disabilities receive therapy and support interventions at specialized centers and schools, and how important that consistency and intensity of intervention is. And we all know that with COVID-19, there have been significant curtailment of services with school closures, interruptions of home-based visits. There have been challenges in how to learn using video conferencing and being able to have home-based caregivers provide that academic support. And then again, for this population in particular, they have a higher incidence of mental health disorders, such as generalized anxiety disorder, phobias, obsessive compulsive disorder, mood disorder, and psychotic disorder, and increased stress to parents. So a subgroup of children in the adolescent group that we need to really focus on making sure they also have access to the vaccine. So what vaccines can we use right now? Next slide, please. Currently, since April 2021, the Pfizer-BioNTech is the approved vaccine for adolescents. As many of you have read, Moderna has put in their application with the FDA. As you can see here, local and systemic reactions occurred in 91% of vaccine trial recipients. And note, those are not adverse events, but just a normal reaction that would occur: pain at the injection site, fatigue, and headache. It is more common after the second dose, and most resolve in 1 to 2 days. And there have not been any serious adverse events that were considered by FDA to be related to the vaccine. Many of you know that after the FDA approves a vaccine through the EUA process, both the CDC and the FDA monitor the safety of the vaccine after it's been released. So there are many ways we do that. We do that through VAERS, the Vaccine Adverse Events Reporting System, where doctors and patients can submit information if they think they've had an adverse event to a vaccine. We also have done it through the text-based VSafe system, where people who receive the vaccine can enter information, and then people can also contact the FDA. Since April 2021, several hundred cases of myocarditis and pericarditis following the mRNA vaccine, the Pfizer-BioNTech, have been reported through VAERS. CDC and FDA have been monitoring these reports to get more details and determine if they are related to vaccination or other causes. Recently reported cases have been mild and have occurred predominantly in male adolescents and young adults after their second vaccine dose, and typically within several days after vaccination. They've responded well to treatment and rest and quickly felt better. I can tell you that as we speak today, the ACIP committee is meeting to talk about the additional results of analysis of those, and we'll hear later today or tomorrow what decisions they have made. Next slide, please. So I'd like to talk briefly about some of the resources we've developed around vaccines that will be relevant for vaccine providers, parents, and teens. Next slide. So we want to make sure that some populations, I hear we have a lot of people here from local health departments and state health departments. I was a state health official in Virginia during the H1N1 pandemic. So understand trying to reach every child to make sure they have an equal opportunity to get a vaccine is very personal for me. It's important that we reach out to adolescents who may be at increased risk of severe COVID-19. And if you think about it, it may be adolescents who are experiencing homelessness. They may live in hard to reach rural areas. We want to make sure we look for racial and ethnic minority groups that may not have as much access, households with lower income. As we talked about, adolescents who may have disabilities, both physical and developmental. And then anybody who's an adolescent living in a congregate setting and potentially hard to reach. Think about adolescents with mental illness, with substance use disorder, LGBTQ+ adolescents, those who may be undocumented, or immigrants, and those who are non-English speakers. Next slide, please. And many people ask questions about consent. The federal government does not have any specific requirements for medical consent for vaccination, which includes COVID-19 vaccines. However, states and jurisdictions have medical consent laws that address the circumstances requiring in the processes for obtaining consent. It's important to note that these laws really vary across jurisdictions, and providers may have to think about those policy requirements within their own organizations, and all sites that are administering vaccines should follow current policies and practices for other routine immunizations in this group. Next slide, please. COVID-19 vaccines and other vaccines may now be administered without regard to timing. This is really important, as we know that over the last year, we've seen a decrease in the number of vaccines that are routine vaccines that are being given to children and adolescents. Adolescents frequently come in to get their Tdap, HPV, and meningococcal conjugate vaccines, and this will be a time to think about how we can catch them up. Next slide, please. Where parents are most comfortable with their teen getting vaccinated. This is a very important survey that we've done. I think it's really important to consider how regular doctor's office, clinic, how do we make sure that patients have access to vaccines in their doctor's office? We at the CDC have been reaching out to pediatricians and family practitioners across the country to have them become vaccinators. Local pharmacies, making sure the hours are appropriate and there's access for adolescents. Doctor's offices, indoor clinics, children's schools. These are all opportunities to be able to meet parents where they are. In particular, it's important to have sites where if you have a child who, because of their developmental disability, hyperstimulation might be a problem, that you can set up a place where they can come in where it's quiet, safe, and they can be vaccinated and not feel intimidated. Next slide, please. And so as we at the CDC look at our strategy over the summer for increasing vaccine access for adolescents, as we talked about, beginning in May, we were augmenting the existing infrastructure for vaccination. So working with our state and local health departments, the federal vaccine partners, the pharmacy vaccine partners, and the large healthcare systems that we're already vaccinating. Also, as I said, strategically adding providers that can reach adolescents. And then in August and September, working again along with all of you to think about school-focused strategies that might ensure that those children that didn't have an opportunity in the summer to be vaccinated will have that opportunity in the fall as they come to school. And very quickly, the last 3 slides are, will get put in the chat box, but they are examples of resources for parents and adolescents. Next slide. There are infographics and toolkits about how to do many of the things we've talked about to provide information. And those are both for healthcare providers, but also for families. Next slide. We have resources for providers and community-based organizations. And then lastly, next slide is the links for communication resources. Also importantly, we've worked very closely with Georgia Tech to make sure all of our information is also accessible for people with low literacy, that it can be translated, and for people who may need ASL or hearing additional focus. So with that, I am going to stop and turn it over to Dr. Waddell. Thank you so much for the opportunity.
Great. Thank you so much, Dr. Remley, for sharing all of that such important information with today's audience. So now I'm delighted to now turn the program over to Dr. Nicole Alexander Scott to share some important information and experiences from the state of Rhode Island. Dr. Alexander Smith, to you.
Thank you, Dr. Waddell and Dr. Remley. It's an honor to be able to join this panel with both of you and to help address some of the very real challenges that we are facing together. So to all of you who are tuned in, we also value your input and your work on the front lines. So to jump right in, the next slide, Rhode Island is in a very good place overall. All of our key metrics are trending very low and in the right direction, as is anticipated for this summer timeframe. We've been able to safely reopen schools, the economy, and most aspects of life through last year and continuing forward now at an accelerated pace, particularly with our strong vaccination rates. However, we know COVID-19 is still here, and our biggest push now is to be able to prepare for the fall. For the percentage of our population who is not vaccinated, they may not experience any challenges with that now, given the seasonal approach that we're seeing, but it will be exposed in the fall if individuals are still not vaccinated, and really helping to get that message out so that we minimize having the type of significant second wave that we had last year by having as much of our population vaccinated as possible in advance of the fall this year. Along with testing and treatment, vaccination is our top strategy so that we can sustain the gains that we need to prevent against having the types of outbreaks in the fall that would hinder reopening schools and the economy. We need to be able to keep them open, and we know that our vaccination campaign is critical to doing that, including the campaign for children and adolescents, which we are ramping up amidst high uptake rates in adults who are setting the model very well. The next slide, and then the next slide, goes into a little bit more about our vaccination opportunities for adolescents. Rhode Island opened up vaccination opportunities for adolescents age 16 and older on April 19th and ages 12 to 15 on May 11th. They've been able to receive vaccine across all channels, which include our mass vaccination sites, all of our pharmacies, primary care providers that have partnered with us, hospitals and home health agencies, and municipal school clinics. As you can see from the age band table and other figures, we present the data in a couple of different ways to align with our national partners' presentation. Overall, almost 49% of adolescents aged 12 to 18 have gotten at least one dose of the COVID-19 vaccine. Included in this is the 41% of kids aged 12 to 15 in just the 5 weeks since the Pfizer vaccine was authorized, and about 45% of the group that's 12 to 18 has been vaccinated through our mass vaccination centers. Between 20 to 25% have been vaccinated through school-based clinics with our local municipalities. So this gives you a snapshot of what our uptake has been both in our adult population as well as among our adolescents, which we're looking to follow closely with. The next slide shows that since April, we have worked with municipalities and schools in partnership with the Rhode Island Department of Education, or RIDE, to offer local school-based clinics at high schools and starting mid-May, also at middle schools. To date, more than 120 clinics have been held. 8 more are planned, with more to come. And by the end of June, all students will have been offered a chance to get both first and second doses of the vaccine at a local school-based clinic in their district, with the additional availability of pharmacies and the mass vaccination sites that are open to also get vaccinated in any of the channels we have available. As we know from previous efforts and national research, school-located vaccination is an essential strategy for child vaccination campaigns. We aim to continue to partner with our school nurses as a key way to do this effectively as part of our campaign. They are ideally placed to identify students who may have missed vaccines and may be key for adolescents who have significantly lower rates of vaccination due to lower rates of their primary care provider office-based visits. We've been actively engaging with primary care providers, pediatricians, and family practitioners as well through our primary care network to build the provider-based capacity in addition. So far, 28 have been onboarded and 10 are administering the vaccine actively. That's another place where we continue to learn in real time about what's working and what's not. To go to the next slide, we can talk a little bit more about our campaign strategy. Like others, we're really just starting in earnest and looking to ramp up. We don't have insight yet into how effective the strategy is, but we can lean on what's been in place in the past, as well as additional important formative research to guide us in the best approach to go. So in a survey last month, we heard what Rhode Islanders think about vaccinating children against COVID-19. The good news is that 80% said they supported vaccinating children against COVID-19 if the CDC says it's safe, though it depends upon their age. 33% were comfortable vaccinating all children newborn to 17 years old. An additional 10%, so 43%, were comfortable vaccinating children 2 years of age and older. And with 74% comfortable with age 12 and older, the current age with emergency authorization for the vaccines as we know it now. 20% are not comfortable vaccinating any children. Also, you can see the concerns that they have with vaccinating children here. While 29% have no concerns, 30% are concerned that the vaccine may make them sick. And then there are a variety of others. 12% felt that kids are healthy, so it's not necessary. And 10% say they are just not comfortable with vaccinating children. The next slide shows that some of the key questions and concerns are around safety of the vaccine, and in particular, they're linked to the speed at which the vaccines were developed and the emergency authorization administered. And so that was considered proof that we don't have enough data about it and leads to the wait and see approach. Overall, there seems to be a fear that we simply do not know enough about the mRNA vaccines and what they will mean for our children. Another pervasive idea that we've learned is that the risk of post-vaccination effects or side effects is greater or more severe than the risk of children getting very sick from COVID-19. We've also learned that the biggest carrots for adolescents and their families to get vaccinated may be the opportunity to get back to normal activities without masks and the opportunity to travel and certainly be able to see loved ones that they may have been disconnected from. Polling, focus groups, and community discussions with Rhode Islanders all have advised us that we will need to be very careful in an approach on incentives for vaccinating. While they can be useful to encourage uptake, there are risks that they can be misunderstood as suspicious if incentives are included. Like, why is the government trying to bribe me? That has been some of the feedback that we have learned in some of this formative research specific to incentives. The next slide shows that we can draw on not only the formative research, but past learning experiences from influenza vaccines, H1N1 version of that, and our human papillomavirus vaccination campaigns in Rhode Island. We also know that the COVID-19 pandemic and vaccination approach presents unique challenges that we are learning in terms of what is going to be most effective in real time. So we're excited to contribute to that knowledge base locally, regionally at the state level, and join with our partners nationally. The next slide gives us some ongoing approaches that we have taken. One particularly important partnership for our pandemic management in Rhode Island and the response has been with the Rhode Island Department of Education. Together, the Rhode Island Department of Education, Rhode Island Department of Health, the Governor's Office, our Rhode Island National Guard, who has been instrumental, and several other state agencies stood up an innovative, effective, and unifying body that catered to school leadership and community members. We refer to it as our Education Operations Center to align with what we are more familiar with our usual emergency operations centers. But what we've been able to do is really provide the support services listed here. It's facilitated our ability to develop the same understanding, purpose, and vision for students across the sectors in Rhode Island. Together, we were able to help schools to open in September last year, and over time, increasingly offer almost 100% in-person learning opportunities for pre-K through middle school age students, and full or hybrid opportunities for all of our high school students. We've recognized the value of working together in this interdisciplinary way, and will leverage that partnership and focus of resources to encourage vaccination of adolescents and younger children as we move forward. The next slide shows that we have some key approaches that we employ to guide the tactics, which include meeting people where they are, regular and targeted outreach, and working with trusted messengers. Our best spokespeople for presenting the facts are pediatricians, school nurses, and other healthcare providers. We know it's helpful to work with other trusted partners who may be famous or well-known as we facilitate these conversations, but we have learned from the feedback that it's important not to have them as the main messengers of such critical clinical information. We really want to engage our clinical community. On the next slide, you'll see a few examples of our collateral. We have a vaccine competence flyer that we've used to address key questions, concerns, and misinformation, and tailoring it to adolescents. We've also engaged social media, as everyone has, to encourage vaccine uptake, and participated in Facebook Live sessions with here Dr. Phil Chan, one of our Rhode Island Department of Health medical directors, to answer questions following the emergency use authorization of Pfizer COVID-19 vaccine for adolescents aged 12 to 15, excuse me. The video spot that can be shared is one of the local pediatricians talking with an adolescent and teen about the vaccine's safety and efficacy. So with that, I will stop there and turn it back to you, Dr. Waddell. Thank you. The next slide shares, and we look forward to questions.
Fantastic. Thank you so much, Dr. Alexander Scott, for that excellent presentation. So we now are going to open up the program for questions from our speakers from today. And so again, please feel free to submit a question into the chat box by sending it to all panelists. And also just be sure to include your affiliation with the question. It's nice to have that context when seeing what the questions are. So to get us started, Dr. Remley and Dr. Alexander Scott, I'm going to ask you this question. What guidance are you giving to families about planning vacations or sending their kids to summer camps, particularly in families with children of mixed ages? It's summertime, folks want to get out, things are starting to open up. What advice?
I'll let you go first, Dr. Remley.
Okay.
Sure.
I'll be glad to go first. Age before beauty, right? So what I would say is we at the CDC have protocols, the CDC guidance around camps and childcare for the summer, but it's really an individual family decision. So if you're thinking about camp, whether it's day camp or sleepaway camp, I would talk with the camp, make sure they're following CDC guidance, have an understanding of where the children come from, if that guidance is being followed closely, but also understanding what the burden of disease is in your community. Because as we're seeing right now around the country, there's significant difference in burden of disease depending upon vaccination rates in those communities. You also want to think about, if you're going to travel as a family, what is the risk and the vaccination status of everybody who's going to be traveling with you? And depending upon when you're traveling, what is the ability of you to be able to socially distance and safely wear masks? So for example, I have a 20-month-old grandson who can't be vaccinated yet, but we call it the cocoon of love. So when we go anywhere, we surround him with people who've been vaccinated. So we're protecting him from being infected, but we also know he is potentially a little bit higher risk of being infected and us not knowing it. So I have a dear friend who has an immune deficiency, and she wears a mask and he keeps his distance from her. So we practice both that safety of making sure you know who's immunized and that you're really practicing social distancing, wearing masks. And then it really becomes an individual family decision. I'll turn it over to you, Dr. Alexander Smith. I'm Scott, sorry.
No, that really was perfect in providing that info. In Rhode Island, we have kept our guidance in line with CDC's guidance, and summer camps have similar health and safety guidance as schools and child care programs with regards to group sizes, cleaning, symptoms screening, and so on. So in addition to the travel input that you shared, which with my 24-month-old, I appreciate as well, getting to be educated on the environments that your children will be exposed to. Different states vary in terms of mask wearing requirements. In Rhode Island, we continue to require masks indoors in schools and child care facilities, and all individuals who are not vaccinated, including children. are incorporated into the requirement to wear masks indoors, but there's an openness outdoors for not wearing masks and being able to ensure that you get to enjoy the summer. So that's a key component that we do want to incorporate into the message, and really use the intention of getting everyone in your family vaccinated as the motivator for being able to travel and having your children enjoy summer camps and other outdoor opportunities once you're clear on the environment that they will be exposed within, and that those environments are following policies that are in line with what the CDC has recommended.
Great, thank you so much. Really sage and important advice to all of our audience here today. So I'm going to turn to Rachel, who will chime in now to ask some of the questions that we are hearing from our audience. Rachel.
Yes, thank you all for the great questions that are coming through on the chat. Please feel free to continue to submit those. This first question is for either of our speakers today. It comes from Tara Bostock at the Washington State Department of Health. She says, I know the rules vary across states, but what would you recommend as best practices for consent and for reaching unhoused and unaccompanied minors?
I'm going to let you do that one, Nicole, because you live and breathe it every day.
Well, it's a great question. It's one that we have essentially used in following our approach with vaccinating youth overall. And a necessary step is to fold this in as a similar rule of thumb in ensuring that parents are able to consent when they are with their children, and children 16 and older are able to assent to their own vaccination. And working with unhoused and unaccompanied minors, as mentioned, does differ by state. Where we are able to encourage an opportunity for an unaccompanied minor that's interpreted as being somewhat independent to assent to their own vaccination for their own safety, particularly given the vulnerability of being unhoused or unaccompanied, it's something that we would want to facilitate. So those are unique scenarios, but opportunities where we can support the individuals who are making important decisions for themselves in their own lives in particularly challenging situations is the general approach that we like to take.
Thank you, Dr. Alexander Scott. The next question is from Sarah Carone from the Children's Cabinet. And this is for either of our speakers, and she asks specifically about what messaging are you finding is most effective to address parents' concerns regarding long-term risks and balancing that with vaccine confidence and things like that. What's been effective to address that hesitancy?
Sure, I'll start, and I think I'll start just as much as my role as a pediatrician for over 40 years and having these conversations about vaccines, but then also the information we have available. We now know, we're coming up on a pretty, at least a year and a half of people who were vaccinated in the initial trials and have not found any long-term problems. The technology, while new for vaccines, is not a technology that was brand new. And understanding how mRNA works makes it really a very safe process and procedure. I walk through with families, with parents, even with pediatricians that are concerned about this. Was, if you take the amount of people, researchers, trials that were done, yes, it was compressed in time, but if you added up the quantity in that period of time, there was more work done about this vaccine than any in recent history. I would say probably any vaccine. The other thing that's really important is we have a more robust system than we've ever had to really be able to identify any kind of minor side effect, any kind of impact. If you look at the incredibly rare incidence of we all learned about, a venous thrombosis in a very small group of people, we were able to identify that quickly, share that information, and have that be part of people's decision making. But I also think ultimately for people to really think about how devastating COVID is for families and for individuals, how many children in our country are now orphans this year that were not last year, and how we want to do everything we can to prevent people from having that infection. And then the last thing I do is I talk about, again, how important it is to me as a grandmother and a mother and a daughter-in-law to protect everyone in my family. And I've made the decision to really encourage everybody I know to get vaccinated.
And the part that I'll add that we also bring attention to, particularly to combat the concern of the vaccine versus the illness itself, is the notion of variants that really has become predominant throughout the country. And people have seen the very unfortunate situations that have occurred with the Delta variant and others, just using language that folks understand and are familiar with, and help make clear that natural immunity, if someone has had COVID-19, particularly over the last year, may not work specifically against the emerging variants that are continuing, where we do have data with the vaccine showing that it works. So when we emphasize the message that Dr. Remley said about the significance of COVID-19, the disease, and the importance of the vaccine to be able to protect against that, it's with the added understanding of the variants that are controlled for effectively with the vaccine in ways that you cannot get in other situations.
Great, thank you so much. This is another question for both of you, it is from Sarah Appleby. She writes, I'm from a health department in rural Northeast Wisconsin. Getting back to normal, unfortunately, doesn't resonate here, as our schools were open for in-person learning the majority of the school year. Besides that message of getting back to normal, what are the most effective messaging for parents, especially considering rural areas where there might be different views about the seriousness of COVID-19?
Thank you for that. I can jump in as a starting point. It does reflect the value of meeting people where they are, understanding what is critical and key. In the Northeast, for example, with everything being, pretty densely populated in urban areas, the opportunity to travel and get away to other parts of the country or see other family members or loved ones has been a helpful driver. If it's about also understanding what's going to be needed to make it so that in the fall, we won't have people missing school or out of work because of not getting vaccinated enough, and with the variants in place, causing the types of peaks that have happened over the last year, particularly the fall last year. That may be another approach to help ensure that people see the value of getting vaccinated. We've continually had to remind folks not to just rely on their own immunity or herd immunity as a notion that if all people around them get vaccinated, then that will be enough for themselves, because the herd immunity does not protect one individual for being more susceptible against the virus because they are unvaccinated. And trying to work one individual story at a time is certainly what we have been focusing on, being delivered through trusted messengers, loved ones who have already been vaccinated, clinicians, school nurses, teachers, those types of community leaders.
And I would add, I think one of the most important things as pediatricians we learn is to find out what people know and don't know and what their worries are first, rather than starting off lecturing or providing them with a lot of information. So, are you comfortable with childhood vaccines? Are you not? What do you think about COVID? What do you know? What have you learned about the vaccines? How can I help you? And then meeting people where they are. If they say, I don't want to do this now, can you come back and talk with me again in 2 weeks? Because you never want to say never, and you never want to shut the door. You wanted to continue to have those dialogues and have those young adults have an opportunity. I've also been surprised at how many young adults are now and adolescents are now educating their parents about what RNA is and how vaccines work. And it really is also an opportunity to work with adolescents who maybe in biology class and understand the science and can help teach their family members how these vaccines work and why they make a difference.
Thank you. For the next question, I'm actually going to combine two questions that we got. They're both for Dr. Alexander Scott. One has to do with what incentives have you tried for adolescent vaccination, if any, and what was the outcome? That is from Riverstone Health in Montana. And then from Raylan Robertson from Made Save, what does a youth-facing vaccination event look like? So those events and incentives that are adolescent-facing, children-facing, what's working, what are best practices that you can speak to?
Thank you. So for the first question regarding, and I just blinked on it.
Incentives. Maybe I shouldn't have combined the two.
Thank you. Thank you. So with incentives, we have focused on keeping it local and attempting to engage at the community level. What incentives would work well, neighborhood by neighborhood, instead of it being like a massive lottery or big amount of money that goes out, trying to see, similar to some of the examples that were shared, what are some tangible, helpful tools, a gift card to, there's Dunkin' Donuts or getting lemonade tea or something here in Rhode Island. People, Rhode Islanders know best which ones work well. But using some of those smaller items that people consider supportive have been the approaches that we've explored more so. But this is really just the feedback that we've received locally in Rhode Island, so I would encourage ways to either engage at your local, state, or regional level, what type of input you're getting, and go with what works. If there is an approach that's working well, we want any and every opportunity that works well. For a youth-facing event, we have also gone with a variety of possibilities. Certainly what I shared about engaging with our local schools has been critical. We have an amazing organization that supports our Vaccinate Before You Graduate campaign for all vaccines. And so it's an environment that youth are comfortable with. And we want to continue to support that, as well as support our primary care providers, and then use social media to hear from youth what they think works well and be able to communicate to them in ways that are most effective. And as Dr. Remley shared, empower the youth to be able to educate their adult parents on what's going to work well and how this will be effective. It's similar to the challenge we faced with the HPV vaccine among youth, but we've been able to accomplish amongst the highest rates in the country regarding HPV vaccine, really just meeting youth where they are and working with their parents and clinical providers. So we're leveraging those successes to build on the approach here.
Great. Well, I think we have time for one, potentially two more questions. There's been so many great questions in the chat, so I'm sorry if we are not able to get to everybody's. But this question has to do with returning to school, and we are going to speak about that in the future. But this question is particularly about how getting kids back to school in the fall will support the full picture of children's health, considering mental health, learning, peer interaction, along with COVID-19, and how are you communicating that to parents in this topic of children and vaccinations?
Okay, so getting children back into school and the multiple levels of advantage that brings has been a message for us since the fall and throughout, and why we have been able to reopen. Our Education Operations Center has been a very helpful resource for doing that. And to tie in the question that I saw in the chat related to that, it's also been the opportunity for schools to have a go-to place to get those type of questions answered and to help get the logistics for making sure students are comfortable, that the mask wearing is in place, that the distancing is in place, and that the vaccinations are provided well, and use that to reiterate getting our schools reopened so that children can benefit nutritionally, physically, intellectually, emotionally, which is a huge one that so many parents are experiencing, and then make it so that parents can get back to work and our economy can reopen. Linking them has been a critical piece. Dr. Remley, I'll pass it to you.
I would add to that, we at the CDC have actually published some studies where we looked at, emergency room visits for children and adolescents, and saw that while they went down during the first 6 months of the pandemic, they rapidly increased for mental health problems. So clearly, this is for all of us been a very disruptive year and a very difficult year, and many people have whatever version of PTSD you can have. But for children, for middle schoolers and adolescents to be out of a socialization environment has really been difficult. And so I think as you have the conversations about back to school, how does vaccination become part of giving your child the most vibrant experience they can have? Whether it be, as Dr. Alexander Scott said, it's emotional, it's physical, it's mental, it's all their well-being combined, and having that conversation about vaccination is really important as part of that continuum of how to provide their child with the best environment. And I would encourage everybody again to think about who are your pediatricians or family practitioners in your community that people listen to. Where do most of the kids go? Because they can be some of your best quiet advocates to have that conversation with a family who may have been there when their child had a seizure, when they had a fever, when they were 8 months, or when they fell out of a tree at age 6 and they had a broken arm. So they have that history to be able to talk with the family and put all of this into perspective is really going to be important as we go from mass vaccination to sort of what I call the ground game, which is really, one house, one family, one neighborhood at a time.
Thank you so much. Really such sage wisdom from both of our speakers for that final question. I'm going to pass it back to Dr. Waddell to talk through what's coming next, as well as ask you a final question. So please stay on for the last couple of minutes. I'll pass it back to you, Dr. Waddell.
All right. Thank you so much, Rachel. And thank you again, Dr. Remley and Dr. Alexander Scott, for taking the time to share all of your insights and for joining us today. And we certainly thank you for all that you do for public health each and every day. There's been some important information shared about messaging on children and vaccinations and other COVID-19 communication needs. There are important resources available on the Public Health Communications Collaborative website, which you can access at publichealthcollaborative.org. You'll see some mass messaging information, as well as some tough Q&A for the kinds of questions that many of you are likely being asked on a daily basis. So we invite you to check out these important resources. Certainly the Public Health Communication Collaborative's mission is to support public health officials by providing communication resources and guidance that you need. So please do take a moment to answer the question that will come up on the next slide in the WebEx platform about the resources that would be most useful to you in the coming weeks and months. So here's the question. What types of communication resources from the Public Health Communications Collaborative would be most useful and valuable? And select all that apply in this instance. So we'll give you a minute to do that. So, you know, people certainly learn and receive information different ways, and the collaborative wants to continue to be that resource to you and provide information that would be most helpful to you. Got a little bit more time to answer the question. Infographics, op-ed templates, tough Q&A. They continue to build on that. It's about 30 more seconds here. Okay. So thank you so much for participating in that poll question. We want you to know that our next webinar, if we'll go to the next slide, will be coming up soon. And we also want you to know that in terms of what you said would be really helpful, infographics, those one-pagers, certainly things for social media would be really important. And it sounds as if many of you are utilizing the tough Q&A, and then information around misinformation alerts are also really helpful. So thank you for that feedback. The team will certainly utilize that as they move forward. So now, in terms of our next webinar, it will be on July the 21st of 2021. The topic will be COVID-19 and return to in-person learning, communicating with constituents. We will have 3 key speakers for this next webinar. Dr. Dave Chowsky, the Health Commissioner with the City of New York, Dr. Ann Zink, the Chief Medical Officer of the Alaska Department of Health and Social Services, and then Daiubila Threets, who is a Senior Advisor at the National Education Association. So stay tuned for registration details that will be coming soon around that. And again, as we close, for more resources around communicating around COVID-19, again, we invite you to visit the website, publichealthcollaborative.org. If you want to contact us, please do that at info@publichealthcollaborative.org. If there's anything that the organization can be helpful to you. Later today, you'll receive a short survey. We ask that you please provide feedback on today's webinar. Again, it helps us to tailor the offerings for next time. And a recording of the webinar, again, will be available on the website a little later this week. So thank you so much. We look forward to having all of you join us for the next one on July the 21st. And again, thank you for all that you're doing to continue to protect the public's health. Have a great day.
Thank you.